Welcome everybody to our webinar on intimate partner violence within the SMVF community, which is taking place today on April 16, 2024. I would like to introduce to you your moderator for this webinar, Ms. Stacy Owens. Ms. Owens serves as SAMHSA's Military and Veteran Affairs Liaison. In this role, she facilitates collaborative efforts to enhance mental health for service members, veterans, and their families. With 20 years of diverse healthcare experience, she previously served as a public health advisor in SAMHSA's Center for Substance Abuse Treatment. Prior to SAMHSA, Ms. Owens dedicated 13 years as a clinical social worker for the SMVF population at VA and DoD. Alongside, she works as a PRN mental health clinician conducting suicide risk assessments for incarcerated individuals. Ms. Owens hails from a proud military family. Her father is an Army retiree, both grandfathers were combat veterans, and her niece is a cadet at the United States Military Academy at West Point. So with that, Stacy, the floor is yours.
Thank you so much, Chantel. Hello, everyone, and thank you so much for joining us to discuss this important topic, intimate partner violence in the military and veteran community. This is a topic of importance and impact for our service members, veterans, as well as military-connected families. In fact, a recent VA study shows that over 18% of women veterans receiving primary care from VHA report experiencing intimate partner violence in the past year. To really honor and highlight the importance of this topic, the Biden-Harris administration has actually issued the first ever U.S. national plan to end gender-based violence. This really promotes a whole of government approach when addressing the topic of intimate partner violence and gender-based violence in our nation. Next slide, please. Next slide. The views, opinions, and content expressed in this presentation may not necessarily reflect the views, opinions, or policies of SAMHSA and HHS. Next slide, please. This webinar is being sponsored by SAMHSA's Service Members, Veterans, and Their Families Technical Assistance Center, which partners with states, territories, communities, and tribal nations to increase behavioral health support for the SMVF community. SAMHSA is the agency within the Department of Health and Human Services that leads efforts to support the mental health and substance use treatment needs of all Americans, including the needs of the SMVF community. Next slide, please. SAMHSA's Technical Assistance Center approaches the support in a number of different ways, focusing on strengthening ongoing military and civilian collaboration, providing a centralized mechanism for jurisdictions to learn, connect, and share, increasing awareness of and access to resources and programs that strengthen behavioral health for service members, veterans, and their families, supporting coordinated responses to behavioral health needs of service members, veterans, and their families, as well as encouraging jurisdictions to implement promising best and evidence-based practices. Next slide, please. The SMVF TA Center does that through a number of different training and technical assistance activities, including academies, crisis intercept mapping workshops, webinars like this one, learning community series, technical assistance calls, as well as subject matter expert consultation, and general resource dissemination on behavioral health topics related to SMVF. Next slide, please. For our webinar today, we have the learning objectives that you see before you. Plan is to explore the prevalence and impact of intimate partner violence within the SMVF community, review the resources available for IPV intervention and support, as well as discovering strategies to foster healing and recovery for those who've experienced IPV, understanding approaches to provide services to IPV users, as well as learning from best practices and identifying and addressing IPV. Next slide, please. To explore this topic today, we have three dynamic presenters who we are very grateful for. They are going to share on this topic based on their subject matter expertise and their sphere. We'll first have Dr. Kyle Ann Hunter, who is a political scientist with RAND. She'll share from her perspective of being a service member herself, as well as her roles in the military, as well as her current research priorities with RAND. Second, we'll have Dr. Tova Kasdan, who serves here at SAMHSA as SAMHSA's point of contact for gender-based violence and human trafficking. She'll give us an overview of that new U.S. national plan to end GBV, as well as discussing SAMHSA's efforts in that vein. And last but not least, we will hear from Dr. Leanne Bruce, who leads the National Intimate Partner Violence Assistance Program at the Department of Veterans Affairs. And she will share from the unique perspective of VA's IPV assistance program. Next slide. So first up, we will have Dr. Kyle Ann Hunter. As I mentioned, Dr. Hunter serves as a senior political scientist and professor of policy analysis with the RAND Corporation. She came into that role from a position within the U.S. Air Force Academy, where she was director of the Strategy and Warfare Center there. Her research interests include military gender integration, suicide prevention, sexual assault and harassment prevention, gun violence prevention, and the impact of emerging technologies on military personnel policies. She's published extensively on the above topics, and we are grateful to hear from her today. Dr. Hunter, the floor is yours.
Thank you so much for having me today. And for everyone here, I am putting my email address in the chat to everyone. I am going to have to unfortunately sign off a little bit early, but if you have any questions, I am more than happy to follow up with you via email. So today, as mentioned, I want to talk about some of the consideration for women's veterans, but really through the backdrop of understanding what are the experiences that women go through when they are in the military, and how that then shapes and frames the way in which women veterans navigate the civilian space. Next slide, please. So the real bottom line up front that we want to talk about today is that experiences that women have while they are active duty, while they are serving, does shape their veteran experience. It shapes the way in which they transition. It shapes the way in which they navigate the civilian space, and it shapes the way in which they have their self-identity and the way in which they interact with others. And then one of the things that's really coming out of the new research and also being addressed by several of the new policies that have come out is that we know that intimate partner violence and sexual assault, and I'll talk in a little bit as to why I am talking about these two things at the same time, and some of the questions about the data that we have are often amplified by the experiences that women active duty service members have with the military healthcare system, and in particular with reproductive healthcare. And so we see this reinforcing cycle where experiences with violence and experiences with healthcare or the lack of healthcare work together to then really shape the veteran experience in a unique way. Next slide, please. So I want to take a step back before we start getting into the data and get a little like nerdy and theoretical here with you. I am a political scientist by my background. I also often say I have sociology envy, but want to sort of pull out a macro lens and think about all of the data that's going to be thrown out today under the context of the military as a gendered system and a gendered institution. And what we're going to so what we want to get at here is that we're not talking about necessarily individual experiences of sexism and the like, or individual experiences with violence, while those do very well exist, and we will be getting into those individual experiences in the data, but that the institution as a whole is gendered in a way that privileges the men within the institution. And it is, and for that reason, that women have been sort of by design marginalized, which again amplifies their experience with violence. So, to think about, just to set some definitions, as we think about gender, we're talking about cultural definitions of masculinity and femininity. We're here not talking about biological sex, or the physiological aspect of people. We were talking about how people present, how people navigate their way in the world, and that this is both something that people do, they perform gender in how they show up in their daily lives, but it's also something that structures impose on individuals in terms of expectations, preferences, as well as access to avenues of power that then in turn can either mitigate or exacerbate experiences with different forms of violence. Next slide, please. So in thinking, and you can roll real quickly through the next one, because it's going to highlight some purple boxes here as we go through it here. So when we're thinking about the gendered system, and this really comes from sociological literature, we want to think about the macro, how institutions exist. So what are the norms and distributions of resources that exist? We all know, I think everyone on this call will be very aware that the military has preferenced masculine norms in the way that people act, dress, engage, distribution of resources. We can get, anyone wants to get like super nerded out on sort of how uniforms are designed, how equipment is designed, and all, on that things, they're designed for male bodies that exist. And so from a macro perspective here, really at the big institutional level, the masculine is preferenced and the feminine is marginalized. From a meso perspective, with the idea around, this is sort of how units exist, right? We see this play out just as well, right? So this has to do with how behaviors exist. Who gets chosen for command? Who gets chosen to be mentored? Who gets believed in a variety of different circumstances that we have? And then from an individualized perspective, we see how individuals take on identities. And in talking to women who have spent time in the military, and I will even say for myself, I was included in this for the vast majority of my career, there's this belief that in order to succeed, in order to be taken seriously, one must absorb and assume the masculine ideas. So regardless of how your own gender, you feel about your own gender presentation, your belief about your own gendered expression, there's the sense that if I want to be successful, my gendered self must become much more masculinized. And so with this, we create a system of structural sexism. Wow, say that 3 times fast for something here that is very distinct from just sexist behaviors by individuals. And often what it does is it negates, undermines, and normalizes individuals' behaviors. And so regardless of the attitudes of individuals, you'll often hear, I'm not sexist, I wouldn't do anything that way. The system is set up that those are the normal behaviors that exist. And so with that, it becomes very different to break cycles of violence that exist. Next slide, please. And so how do we see violence sort of interacting under this, under the system? And I know these are like very small charts. We will make sure you all get, I think everyone gets a copy of these so you can dig into them that we have here. And so thinking about abuse and violence under this gendered system, there's a few key things to look at what the data tell us right now. One is that, over the past, essentially dozen years or so, we've seen reports going down, yet the number of instances that are meeting the criteria from survey remaining about the same. And so this really highlights how, especially under the sort of the removal of the women in ground combat exclusion, the push and advancement for women, things like the strategic framework and implementation plan for the WPS Act, that as the institution is trying to push for more women to become involved, we're seeing backlash and gender or violence against them remain the same, yet a reduction in reporting actually occurring. And so this is so essentially what we're seeing is those individual women who are trying to navigate the system rather than reporting are actually choosing to remain silent, which is incredibly important in this. Another thing that is, I think, important to look at in terms of pay grade of the victim is we often think about violence that's occurring against service members as occurring against our most junior service members that are there, when in fact, this is actually happening most often at the mid-level that we have, that E4, 5, 6 level. And again, feeding into this, to be able to understand this, feeding into this idea of the military as a gendered system becomes really, really important, because this is women who have made it, who are on the up and up, who have now assumed leadership positions, and they are the ones who are most at risk to experience these negative behaviors that we see. And the other thing to think about with regards to intimate partner violence that we see is that the vast majority of these incidents are directly physical in nature. And how these things are parsed out, like a sexual encounter can have physical, but when we think about a physical violence that occurs, it means that there was a form of injury behind this, and that there was the intent behind the act also included a form of violence. So big takeaways: we're seeing reporting go down, we're seeing the mid-level folks at the most risk, and we're seeing this being incredibly physical in nature, all against the backdrop of a gendered system that exists. Next slide, please. And so then simultaneously, what we are seeing is also an increase in sexual assault and abuse that is occurring. We're seeing reports sort of move up as time goes, and that's good. I think we all know that reporting assault and abuse, we want to see reports go up. But I think what's troubling here is that we're seeing unrestricted reports. So reports of individuals who are going to actually want prosecutorial action to open up a full investigation, they are on the decline. So women are choosing the option which allows them to remain sort of silent, remain quiet throughout the process. And so with that, there are individual services that women are able to receive, but there's not the cultural impact and aspect that can come from actually addressing these things out in the open. And why talking about sexual assault in an intimate partner violence webinar makes sense is that one of the things that we're trying to tease out much more is how many of these incidences of sexual assault are spousal in nature. And that is something that, as we're seeing more women enter the services, we're seeing more women actually be in partnership with other service members. What we don't have a good sense of is to what extent are these things, these are actual indicators of intimate partner violence that occurs. And so the other big highlight takeaway here is that there's a need to parse out and do much better research on this. Next slide, please. So talking about women's health in the aspect of this is, as we've started to dig in and begun to do qualitative research around the topic, what we are finding is that women's willingness or unwillingness to report, willingness or unwillingness to seek services for violent events that happen against them are sort of reinforcingly framed against this backdrop of access to healthcare that exists. And I think, anecdotally, we hear stories now in a post-Dobb environment of, even if I were to go report a intimate partner violence event, my spouse who was the abuser is going to have more rights than me if it resulted in a pregnancy, right? If there was a spousal rape that resulted in a pregnancy, or if I am pregnant and I am being abused, I don't have access to resources that we have. So there's this particular concern about the national reproductive health landscape and how that frames women's willingness to come forward. And this is particularly of concern for both sexual and racial minority populations. We know that women who are sexual minorities and racial minorities are more at risk for some form of intimate partner violence or sexual violence against them, while simultaneously having a better lack or a greater lack of resources for healthcare, in particular reproductive healthcare. And you can actually move forward 2 slides for this one right now. We don't need to go into the for this one. But so in terms of thinking about this in terms of the post-Dobb landscape and why it becomes important is really this bottom line bullet that we have right here. Is that we know that there is actually now in the wake of some new recent decisions in Arizona and Missouri, this number is up to almost exactly 50% as of just a few days ago. And I apologize that the slides aren't updated for things that are of just a few days ago. And that there are on order of 5,000 to 7,000 women who seek abortion care every year. Again, anecdotally, we're seeing that often this is the result of an instance of intimate sexual violence that has occurred to women, and they want to be able to do this in a quiet manner, to be able to sort of receive self-satisfaction, self-isolation, be able to heal for themselves. But now that that nearly half of the women who are in the services at a time when we're seeing assault rates go up, report rates go down, women are now lacking access to care. Recent policy changes have ensured that women can travel, take administrative leave for non-covered reproductive health care, including abortion. But what we don't know yet is what the impact is going to be on women needing to actually leave their home of record to seek the care that they could have sought closer behind or closer to them. So next slide, please, because I know I'm running up to my 20 minutes here. And so why do we care about this for women veterans? And what becomes important when we start thinking about women veterans is we know that women veterans are fundamentally different from both their female civilian counterparts and their male veteran counterparts. But what is yet to be deeply explored, and where we need continued investment and more research, is on how much of this difference is explained by the experiences that these individuals have had with violence. So I'm going to go through very quickly just a few of these key differences that, as we start to look at them, these are numbers that individuals have probably seen quite a bit before here, but how they play out again, against this backdrop of this gendered system where we see higher than average incidence rates of violence becomes very, very important. So just looking at some of the key demographics, I'm not going to go through every single one of them, but ones that are especially important for this is the bottom here, that they are more likely to be both divorced and divorced than either their veteran men or non-veteran women, and they're twice as likely as their veteran male counterparts to have children living in the home with them. And so thinking about this stat, we think about it a lot with regards to childcare. We very rarely have we seen it framed against what were the experiences with intimate violence that led women into these positions. And so we start to think about what our mental health care should look like, what trauma-informed care look like. Keeping that reality in the backdrop is really important. Next slide, please. Additionally, we also see women less likely to be unemployed, which we'd like to see as a positive, but much more likely to be living in poverty than veteran men that we have here. And so again, putting things against the backdrop of the experiences with violence, the experiences with living in a gendered system, understanding that access to employment might need to look different for these women. Next slide, please. Again, here, when we think about economically, that we have the veteran women who are doing better than their non-veteran women, but again, they're more likely to be divorced with children at home, which may contribute to that poverty rate. And it also may contribute to a inability to want to partner based on previous experiences with violence. Next slide, please. Right. So the key areas for consideration to really be the big takeaways today, as I'll pose these more as questions for everyone to sort of marinate on and think about as we move forward, is how is the gender-specific physical health care against the backdrop of a very gendered system either helping or hindering the ability for women to to receive the care they need to be able to move forward into their veteran life in a positive way. Similarly, the ideas around mental health this way. Are we driving mental health in a real trauma-informed way? What the research shows us is that experiences with IPV or sexual violence lead to very different manifestations of PTSD than combat-related care, that women are most expected to have treated often very similarly. So related to that idea of military sexual trauma, where things are. And then finally, these last two is when we're thinking about how we are ensuring access to family planning and labor and economic resources, ensuring that we are doing so against the backdrop of intimate partner violence, against the backdrop of women potentially existing for many years in a very gendered and violent system, and ensuring that those resources as well, that we often try to think of as being very gender neutral and apply to everyone, are gendered in a way that allow women to live their biggest and fullest lives. And so with that, I will kick it back to Miss Owens.
Thank you. Thank you so much, Dr. Hunter. You gave us some really important information about the impact on active duty service women who serve in a system that is inherently gendered. It was really enlightening to hear about sexual reporting and how that's changed in the military, both in the context of the report rates as well as those reporting methods. And I think that you also gave us some really important points about the alignment between violence and access to physical health care, and ultimately that synergy of physical health care and how it impacts overall mental well-being. Just a lot of key areas of consideration that we could all be mindful of as we explore how to best provide support. So thank you again. And next, we will hear from Ms. Tova Kasdan. Ms. Kasdan is actually my direct coworker here at SAMHSA. We work together in the Center for Mental Health Services Office of Technical Assistance and Coordination. Ms. Kasdan leads the gender-based violence and human trafficking portfolios for SAMHSA. Prior to joining us here, she worked for our sister agency called the Administration for Community Living, where her portfolios included violence against women as well as elder rights. So she's come to the public health space from her prior career as a practicing attorney, and in her work, she does an excellent job of focusing on improving systems to prevent abuse and advance the rights of survivors. Ms. Kasdan, the floor is yours.
Thank you so much, Stacy, for the introduction and for Dr. Hunter for the excellent presentation. So what I'd like to do now that we have the foundation laid is to talk a little bit about the National Plan to End Gender-Based Violence, which is a whole of government approach. Really, we're talking about all forms of violence when we talk about gender-based violence, not just domestic violence, which is also referred to as intimate partner violence, but as our presenters will share with you today, it also includes sexual violence, stalking, and other forms of interpersonal violence and coercive control. And we heard Dr. Hunter talk about that because there's many intersectionalities behind these types of violence. Coercive control can be reproductive coercive control. It can also be coercive control to use substances as a form of power and control in the violent relationship. Excuse me. So there are many ways that we are considering the forms of violence. Next slide. So in alignment with the national plan, SAMHSA has many activities that we're working on. And really what we're working on is this intersection of gender-based violence and behavioral health to improve all health outcomes for survivors of gender-based violence and human trafficking. We participate in many activities, both internally as well as on an interagency level. And within the national plan, we're co-leaders of Pillar 2. The national plan is broken up into 7 different pillars. And Pillar 2 is really focusing on support, healing, safety, and well-being, really the mental health components of violence. And so at SAMHSA, that's really what we're focusing on when we talk about our work. Next slide. So there are many statistics that can be, I know, very stargazing at times when we talk about different forms of violence. But just to set the stage, we know that violence can happen to both women and men, but disproportionately it impacts women. And what we know is that all forms of violence, both physical violence, emotional violence, financial exploitation, sexual violence, many of these forms of violence are co-occurring. So when we pull out certain data and statistics, we're looking at kind of a form of violence or who it may affect in terms of a specific population. But please understand that many forms of violence are happening to survivors at the same time. And looking, at the second, statistic, about 41% of women and 26% of men report having experienced at some point in their lives contact sexual violence. So that they've been touched without consent, physical violence, or stalking. And that's by an intimate partner, someone close to them in a relationship. And so that power and control is really felt. It can be a one-time incident. It can also be a pattern of abuse that can span many years or even decades. Next slide. So at SAMHSA, again, we're focusing on the intersection of domestic violence and behavioral health. And here are some statistics. I'm not going to go through all of them, but to really show how this intersectionality affects women accessing, let's say, for example, substance use disorder treatment. These numbers are really high. 47.9% report having experienced domestic violence in their lifetime, and almost a third report, or over a third, experiencing it in the past year. These are really high numbers. And so what we know is this isn't just a concept, this is a reality that survivors of intimate partner violence and sexual violence, they are very much affected, both their mental health and their use of substances. And what we also see as when they seek mental health services, and many don't, but those who do seek, they're doing it in inpatient, outpatient, and psychiatric settings. So there's really a span, a continuum of mental health outcomes that can occur when someone experiences any form of violence, gender-based violence, intimate partner violence, and really that can be related to someone's stress level. It can go all the way up into serious mental illness and post-traumatic stress syndrome, clinical depression. All of these things are very much felt by survivors of violence. Next slide. When we're also talking about the intersections, we can look at sexual assault and behavioral health. And we know that survivors of sexual violence, and this study states this in this slide, are more likely to engage in the use of marijuana, to use prescription drugs or from non-medical purposes, really using very serious drugs like cocaine, hard drugs that can really impact their health. And so what we know is that victims of sexual assault, they may not just be trying to block out what's happening to them currently, but many have experienced adverse childhood experiences, complex trauma, and they may be using alcohol or drugs to numb or escape this consistent and oppressive sense of, anxiety that is occurring to them. And also we know, as we stated before, that some people are being forced to use or being in environments where the person perpetrating the abuse is using. And so they're very much caught up in that as well. And at its most serious on the continuum, people with serious mental illness have significantly higher risks of violence victimization, including gender-based violence, compared to the general population. We also know at its most serious levels that survivors of intimate partner violence may experience higher rates of suicidal ideation and are at a higher risk of being killed by their intimate partner. Next slide. So when we're talking about risk factors in military and veteran communities, when we look at this data, we're really looking to see that there's not necessarily a causal effect between, let's say, economic security or homelessness or use of substances, but these are exacerbators. And so if you're already experiencing violence, we know that if you're also experiencing economic insecurity or you don't have a safe home to live in, which really makes you homeless, you in fact are at greater risk. And we know from the data that many people experiencing homelessness have experienced sexual violence before becoming homeless. So we have to keep that in mind. Again, these are not separate silos, but there's an intersectionality of violence and other detrimental physical, mental health, and social consequences. We know, as Dr. Hunter pointed out, that experiencing trauma during military service is very impactful. And when we have high risk of domestic violence, we, as I mentioned before, can have increased threats of homicide, suicide. So for those of you who may not be as familiar, we may have someone who perpetrates abuse threatening that if the person that they're abusing leaves them, that they will kill that person and kill themselves. And if they have firearms or access to other weapons, this makes this a more deadly consequence, especially for women who are disproportionately affected. We also have, in my time as a practicing attorney, I was a domestic violence prosecutor. I also saw the impact on families, and there were many threats of custody concerns or taking the children away, kidnapping the children as a form, again, of the power and control. This again can have a really significant impact on a person's mental health and their behavioral health. Next slide. So as we are discussing today, what are some ways we can improve systems so the barriers that are really getting in the way of survivors accessing services are diminished? And, a lot of times what we know is survivors may not necessarily label the treatment that they're experiencing as abusive. And I saw this all the time when I worked directly with survivors of intimate partner violence. If you ask someone experiencing that, are you experiencing domestic violence? 9 times out of 10, they're going to say no. And the reason for that is with that label comes a lot of fear and shame and, judgment. And so very few survivors will necessarily call themselves that or identify the behavior as abusive. It's not because they want to be treated this way, but there may be many concerns. And I've listed some here. Concerns about confidentiality. We know this is really important in military and veteran communities. This idea of someone of a certain rank who is committing abuse against another person, if that's found out, what are the consequences for that person and the family? The survivor doesn't necessarily want the abuser to be punished or taken away. And that's really key. Again, when we talk about survivors, they don't want to be harmed anymore. They want to be safe, but they're not necessarily looking for punishment of the abuser. And this really makes it very difficult in the criminal justice system. We have other exacerbators, which may be relocations or deployments. Again, significant impacts on the family. They are not the causes, but they could be, in fact, exacerbating an already violent situation. And so really the key, and we're going to hear from our other speakers, is, really prevention and early intervention so that it doesn't get any worse. And that's really what we want to focus on. We also want to take note that not every survivor experiences violence is from the same community, culture, language. And so we want to ensure that we have programs, systems that are very survivor friendly and not just monolithic. Next slide. So we talk about opportunities for collaboration, and so this could be when we talk about, you know, forms of the military and nonprofits, you know, culturally or faith-based competent programs, things like that. I always say, let's reach across, let's reach horizontal, not stay in our vertical silos. There are many opportunities for cross-training between the military and gender-based violence communities, and this just makes the knowledge stronger and the response better when we have these relationships in place before a crisis occurs. We want to make sure that our screening, referrals, and resources and safety planning really look across the life course with survivors. So before coming to the government, I also directed an elder shelter. And so we also want to make sure that we're not just talking about people of certain age ranges, but you can experience violence from the time you're a child all the way through to end of life. And so there's very different physical, social, cultural, language, and behavioral health needs depending on the person that we're serving. So when we have these partnerships and collaborations in place, it really creates more positive outcomes for the survivors. Next slide. So I've taken the liberty of sharing some resources, both within government as well as with nonprofits. So please do note that there's many services that are available. Even if you're not sure if you're calling the exact right agency, if you contact, next slide, please, for example, the National Domestic Violence Hotline. You could call them, you can do chats with them. They have resources for the entire country. And so really important, you can also use their database, even if you're just a friend or someone who wants to help, and plug in the location, what kind of services you want, and they will be able to route you to those services. So there's many different types of organizations that can assist. And so my best recommendation is to build a really strong multidisciplinary team and to ensure that you have the resources in your community as well as national resources to assist the survivors and families that you're working with. Next slide. I also, as I mentioned, abuse can happen across the life course, so I'm including some elder abuse resources and opportunities. The last one, the Spring Alliance Elder Shelter Coalition. Not every state has elder abuse shelters for those experiencing abuse in later life, but that website can show you where they exist, and also to be able to locate resources that may be a better fit for those who are older or have disabilities. Next slide. So thank you very much for the opportunity, and I'm happy to answer any questions. There's my contact information as well. I'll turn it back to Stacy. Thank you.
Thank you so much, Ms. Kasdan. We really appreciate you, providing your subject matter expertise on this area. As I mentioned, it's just really groundbreaking that our nation has enacted this national plan to end gender-based violence, as well as having strategies for action that are associated with that plan. From your presentation, it was really helpful to see some really impactful data. It particularly stuck out to me that those who've experienced violence from an intimate partner are up to 4 times as likely to have a suicide attempt than the general population, really bringing home the piece about mental well-being that's important to highlight here. Also some really eye-opening pieces at looking at barriers to accessing services and reporting, things that you mentioned like cultural and linguistic concerns, pieces that are particular to military families like frequent relocations. And thank you also for talking about areas for collaboration and giving us just a plethora of resources. I know we're going to try to put some of those in the chat, but again, these slides will be available to attendees. You'll receive an email after the presentation as well. So thank you again, Ms. Kasdan. Next, I'd like to bring to the floor Dr. Leanne Bruce, who leads VA's National Intimate Partner Violence Assistance Program that is housed within VA's Office of National Care Management and Social Work. Dr. Bruce has worked in the area of intimate partner violence for over 25 years in a variety of settings. And she really has a very unique position because we know that the VA health administration primarily serves men in their settings. So, having this really unique position of leading an IPV program in an environment that's largely serving male clients is a unique position to be in. So we are really looking forward to hearing more about how this program works to provide services to men and women who may be receiving services themselves or may be a partner of someone who's receiving services at VA. So Dr. Bruce, over to you.
Thank you so much for inviting us today. And you can go to the next slide if you want to. I'm also joined by my colleague, Amanda Cracker, and she's going to come on a little bit later. We've actually got some interactivity to do with you all. So I'll try to get through the content part to get to the case that we are going to discuss. I just am glad to be here today. I really have enjoyed the first two presentations so much, and they've made such great points. And it's because of all of those things that the VA has created an intimate partner violence assistance program. That's kind of our little calling card. We are officially called the Intimate Partner Violence Assistance Program, but a lot of what we do in our programming and screenings and things are framed under the title of relationship health and safety, because we really do have programs that run the gamut between trying to cultivate and support healthy relationships while also identifying and mitigating risk related to safety issues. And so, it's a very comprehensive program that you'll see momentarily. And when you get the slides, the links are live, so you can find us, and we'll put some in the chat. If you go to the next slide, I just want to acknowledge that in this large of a presentation environment, interpersonal violence touches nearly all of our lives. If somehow somebody has escaped it in their family, friends, college, relationships, somewhere along the way, then that's wonderful. But I know that it really affects so many people. It's a public health epidemic. So I just want to say that we've talked about a lot of scenarios and situations, and if that's something that's really hits close to home, please, there's a lot of wonderful, and they've given it in the other presentations too, there are a lot of hotlines that you can reach out to, and we really encourage people to share these hotlines and make sure they're posted everywhere, because you never know when somebody might not be wanting to disclose but they'll call the hotline. And so we want to always share those. If you go to the next slide, I won't bore you with objectives, but I do hope that by the time we finish our time here, you know a little bit more about the veteran population with regard to IPV, is what we normally call it. But we also are recognizing that IPV, I'm so glad that Dr. Hunter talked about IPV and sexual assault, because they really are interconnected. IPV and suicide prevention, IPV and substance use, IPV and human trafficking. It's just really in there at the crux of being connected to all of these different things. So we really want to talk about some of those complexities. And we're going to touch on in our case some complexities of just identifying and addressing intimate partner violence in our veteran population. Next slide. So a real quick overview of our program. So we were created about 10 years ago. We're actually celebrating our 10th anniversary. And so we came into being, and there's been a lot of things that are very unique about this program. It started with a task force of subject matter experts that defined IPV for the VA very, very broadly. It's based on the CDC's definition. It's very broad in that we recognize any form of intimate partner violence, including physical violence, sexual violence, stalking, coercion, psychological, emotional, stalking, all of those things we recognize within our definition. This is a scaled down version of it. We also recognize that it can happen with a current partner, a former partner, a spouse, somebody you once dated, any of those kind of things can be an intimate partner. You don't have to live with them. You don't have to have a child with them to qualify for our services and programs and so forth, or to be a part of this definition. And it doesn't require sexual intimacy either. So, an intimate partner is in the eyes of the beholder. If someone recognizes someone as their intimate partner, or they have that sort of relationship, that's part of the definition. The other thing unique about our program is, yes, we serve veterans, so veterans that can come to the VA for their health care, they can come to us for care, but we also can serve their intimate partners. And within our policy, we also can reach out or we can serve and help and support VA staff who might be impacted by intimate partner violence as well. So we're really covering all the bases of recognizing this as a public health epidemic and knowing that it affects anyone. Also, we also provide services for those who experience intimate partner violence and those who use intimate partner violence, as well as identifying and recognizing and addressing bidirectional intimate partner violence. And we do that through a variety of services. Every one of our medical centers have a designated intimate partner violence coordinator. And that coordinator is raising awareness, doing campaigns like this is Sexual Assault Awareness Month over here. And so we put out a lot of things. Every single month we're putting out awareness about intimate partner violence and related issues, educating people on that, doing training with staff, providing universal education, building partnerships because we can't do this by ourselves. And engaging in outreach. We also have a very robust routine screening and assessment process and are engaging in, of course, safety planning. And we have several amazing interventions we'll talk about momentarily. Next slide. I won't go into the stats. Everybody before me did such a great job with that. And, we just echo the same statistics. As I said, we know this is prevalent. We know it's prevalent in the general population. And in the veteran population and service member population, it can be twice as prevalent. Although we do know, they're absolutely right, that reporting, it's underreported. People are fearful, shamed, guilt, embarrassed, all kinds of reasons for not reporting interpersonal violence. We do know that they tend to feel a little bit more comfortable, I think, when they come to the VA and they're not reporting it to their employer. They feel a little safer sometimes. We've had lots of veterans tell us, this went on for years while I was in the military, and I only feel safe enough to tell you now. So that's something. And we do routinely screen for military sexual trauma with every single veteran that comes through the door. And now we're starting to routinely screen for intimate partner violence and several other things. So we know how much it affects all of these other issues. Next slide. I'll just move on because that's already been covered so well. So one of the things that is the foundation of our program is trauma-informed care. And by trauma-informed care, we don't just mean that we recognize that most of the people who come through our doors, veterans, patients, families, staff alike, have most likely experienced trauma in their lives. Yes, we recognize that, but it's more than just addressing the trauma. It's and SAMHSA has such great tools on trauma-informed care. We refer to it a lot of the guides and things in our training. But that is something that we want to make sure is applied across the board to everything we do. And it's an organizational structure where you're thinking in every aspect of your agency and of the services that you provide, that you are taking into account that the person that you're working with or for or providing services to might have trauma that's affecting how they're engaging with you. And it could be, even, the people you're working with, your colleagues and everything. So we really try to think about from making sure that safety is embedded in all of our processes, safety in the environment, that people feel welcome, that they feel safe, that they feel like they're respected, that how they're talked to, all of those kind of things, all the way through the services that we provide, making sure they understand what we're doing, why we're doing it, what we're documenting, bringing them into the conversation to make sure that they are an equal partner in deciding, when to report, what to report, who to report it to, what we're writing down, where we're putting it, where it's going, who can read it. We need to make sure people feel safe in order to report and then engage in the services that we're offering. And it's up to them what they choose to use, whether they want to go in a group or they don't want to go in a group. So all of those things, correct, to respecting the person, thinking even about our language. You heard me say, those who experience intimate partner violence, those who use intimate partner violence, we use that person-centered language in order to take away the stigma and the stereotypes and everything from this issue. And as Stacy mentioned, the vast majority, we have like 10 million male veterans enrolled. We have a little over 1 million. Fastest growing enrollment population, new population, is the women veterans. But they are, a lot, very outnumbered. There's about, 9 to 1, something like that. And so we and in recognition of being respectful of, gender diversity, we really have tried to steer away from talking about this as a women's issue or a men's issue, that this is a human being issue. And we're trying to eliminate some of the labels, recognizing the risks to those who identify as women, recognizing additional risks to those who are gender diverse, are at higher risk for intimate partner violence. They're often at higher risk for not having appropriate services in the community and things like that. So we really are trying to be sensitive across the board with regard to who we're serving and what their needs are. So we're going to go into the case, and I hope, there's time. Okay, we're good, I think we're good. So talking a little bit about this, one of the things that was noted earlier is just how often you have dual military families, so that you or couples. So we're going to talk a little bit about John and Jane. They're both retired veterans who have been married for 12 years. They have both received their care at local community VA outpatient clinics for several years. They have different primary care teams, because she goes to the women veteran primary care team and he goes to a regular care team. You can see kind of their profiles below. John is 43, Jane is 41. He suffers from chronic pain, combat injuries, PTSD, a mild traumatic brain injury, alcohol use disorder in remission, and recent reports of increasing depression. Jane has routine primary care. She did report that she had military sexual trauma but declined services. Her clinic visits have been increasing lately. She's complaining of frequent headaches, fatigue, and sleep issues. So taking these two people in mind, one of the things that we do is, if you'll go to the next slide, is routinely, and at this time, it's required that all women of childbearing age, in accordance with the United States Preventative Services Task Force recommendations, it's required that all women of childbearing age are screened for intimate partner violence. Now, we push really hard for all veterans because you just never know, and it really doesn't make sense to us to cut it off at age and so forth. And many of our sites have this clinical reminder, this automatic screening turned on for all veterans, but we aren't there yet to where we have all of them turned on for all veterans. But so Jane's provider did the screening. It's called the Relationship Health and Safety Screening, and you can see the main part of the screening right there. It's based on the HIT screen by Dr. Kevin Sharon. And so she did. For us, anything that's not never is positive. So if you just say rarely we yell at each other, it's positive, because we want to dig a little bit further, and we want to route people into maybe some relationship health resources. So she did say that rarely threaten, sometimes insults and talks down, and often they're screaming, she gets screamed at. So this is as a recipient experiencing. When the primary screen, the 5 questions, are positive, we automatically pops up a risk screen. And she said that it has been, the violence, speaking of the verbal things, has been increasing for the past 6 months. But she denied strangulation or choking, which is a high risk factor, or believing that he could kill her. So she felt pretty safe, that it is increasing. It's something that she needs some assistance with, or at least to be offered. So as we do that, we would like to, in the Q&A box, we would love to hear what you think. You know, just talking about their profile, knowing them, thinking about the definition of IPV that we presented. Just let us know what you think about some possible concerns. And then there's a poll. Are you able to identify who is experiencing IPV from this? Who's experiencing IPV? Who's using IPV? What do you think so far? And Amanda, are you seeing anything in the Q&A box?
We're getting a lot of really active questions, but I'm not seeing responses for the polls just yet.
Okay. All right, we'll give it a minute. Yep, we've got some questions. Do we have a screening for John? Excellent. We do. So in our system, one of the things that we do, the screening is all about it's triage. It's trying to figure out what is going on. Are there some risks? Are there some potential services that we can provide, all the way from universal education, all the way through some of the evidence-based interventions that we might have to help support healthy relationships and safe relationships. So I can't see the poll either. If you guys can see the poll, yeah, there we go. Thanks. Okay. So we have the vast majority saying that 49% say that Jane. Oh, sorry, Amanda, I was just going on. You go ahead.
All right, so 4%, well, we can read those. 4% for John in terms of who is experiencing IPV, largely 49% for Jane. And this actually aligns with the question that was in the chat, what is bidirectional IPV? So 26% said both, and it looks like 21% maybe are wanting a bit more information. It's not quite clear just yet, which is completely understandable to want to get a bit more information in those assessments. And then, are you able to identify who is using IPV? So 41% mentioned John, 7% Jane, and 16% both. So excellent job picking up on those little details and risk factors.
Absolutely, absolutely. So yeah, you know, if you're a provider and, you know, or it's at your agency and somebody comes and discloses some of this, you're getting part of the story, but you don't have all of the story yet. You know that they might need some assistance. So next slide. As it turns out, we happen to, because it's standard and turned on at their CBOC or community-based clinic, John is screened as well, and his provider, so John actually also reported that he gets screamed or cursed at frequently, and often being insulted and talked down to, threatened with harm, and sometimes physically hurt, denies sexual abuse. And so going on, he also admits that the violence is increasing in frequency and severity over the last couple of months. So now we've got a little bit more of the picture. And if I were if I were the couple, there was a question I think about, you know, how would you know about both? It's entirely possible that one provider sees a dual couple. It is possible, unlikely, because most of the time women would go to a specific women's health clinic. But in this particular case, I might be the social worker that I get 2 consults and they happen to be married. So it is possible that we would know the results of a couple. But at this point, we wouldn't be talking to one about the other just yet. Let's go to the next slide and ask the questions again. So thinking about what we've learned, what is your conclusion now? Are we able to identify who is using or experiencing intimate partner violence? Who is using intimate partner violence? Gets complicated, doesn't it? Give it a minute. While we're doing that, I saw a question about partners. Non-veteran partners can come to us themselves. They don't have to let the veteran know. We don't have to let the veteran know. If they need assistance, they can come to us. Now, we can't always put them in our system and treat them directly like Center for Mental Health, but that's one of the reasons we build partnerships within the community to make sure we, at the local coordinators, they make sure that they can help that person find resources that they need in the community and help them with safety planning. Okay.
All right, thank you, everybody. So are you able to identify who is experiencing IPV? Largely 78% shared that it is both. And are you able to identify who is using IPV? Again, largely 75% is both. And that's absolutely what we wanted to point out with this case example, is it can get very complex, very nuanced. I saw some comments in the chat regarding reactive abuse, and our screen does not necessarily assess for intent. That's something that we would do, at least through VA. That would be one of our next steps, especially as we're looking for treatment interventions, level of care that they may need next, whether or not we would address it from, the side of someone experiencing abuse versus someone engaging in those abusive behaviors. That's absolutely something we talk about after the fact. So excellent job, everybody. I don't know if you had anything else you wanted to add, Dr. Bruce?
No, not really. You covered it, and you guys are great in the chat, but we'll try to get back to some of the questions too. You've got a lot of great questions in the Q&A box. We'll try to get to those too. But absolutely, and some of the next steps you're fine, you can go on. Some of the next steps really would be to do offer them a further assessment. They can totally decline. We offer universal education is one of the first things that we offer. And that's whether people agree to the screening or not, or screen positive or not. Universal education really is just plastering that information everywhere, offering it to people, offering some things about healthy relationships, getting that hotline number in people's hands, because sometimes they will not ever tell us. We can screen them every single year, and they still are not going to open up necessarily, but they might call the hotline number, and we actually have a relationship with them that they give us information about veterans and veterans partners who are calling, so we know people are using it, and we know how important it is, and so that universal education helps people understand, hey, we get it, we understand relationships are hard, we've got services that we can help get you into, and to help make things better. We have tons of resources and training for our staff and providers on safety planning. Another thing that we promote and think a lot of is the MyPlan app that was created through Johns Hopkins, and some research there. It's really nice because it's a very covert way that people can assess their own risk on their phones and have a safety plan right there in their hand. And then in the VA directly, we have therapeutic programs aimed at these evidence-based therapeutic programs. We've got Strength at Home, that is for veterans who use intimate partner violence or might be at risk of using intimate partner violence. We've got the RISE program, which is for veterans who have experienced intimate partner violence. We have a group called Courage Group, which is for veterans who have experienced any form of sexual violence. And we've got a multitude of other programs through our mental health services. Some VAs have family services programs. Our chaplain services have programs that help to enhance relationship skills and so forth. So there's tons of things that we have internally, and as well as using what's in the community and helping people find what works for them. So next slide, and we're just about done. I think we're okay on time. Just to, some of the things that we want to do next, maybe for our couple, is teach those safe, healthy relationship skills. Dig in and find out what's going on in that couple's life that is exacerbating this stress with one another. Maybe there's other stuff going on. Amanda and I are trained as clinical social workers, and so, digging back, peeling back those layers of what's going on, to find out if there's, social determinants of health or social drivers of health that are exacerbating the stress on this couple that's been married for quite a long time. And so we really want to dig in and see if we can help from a holistic perspective. and find out what's impacting their relationship, and see what we can do to help. And it is important to encourage bystander empowerment and people who can step in. You never know who a veteran might be comfortable talking to. It could be a peer counselor or someone that they're in contact with. So we really want to empower. We're trying to establish a no wrong door kind of service so that wherever somebody enters our system, people are knowledgeable about talking about these issues. And so with that, I'll just go ahead and close. We've got, if you go, there's some links there to our website. We'll pop that in the chat box too. This is our team. We've got a group email at the bottom there that you can contact any of us if you have any questions or you want to find out who your coordinator is at your own local VA area and you want to pick their brain or see what resources they have. You can reach out to that one email and get all of us. And with that, I'll just end, and we will be around to answer some questions, and we'll try to catch everything in the chat box. Thank you, everyone.
Thank you so much to Dr. Bruce and Ms. Cracker for taking us through this presentation as well as that interactive piece. I have to say that I attended a presentation that Dr. Bruce gave probably about a year and a half ago. And as we were planning out webinars for the SMVF TA Center, I thought back to that presentation, and that was a little bit of the birth of this webinar, so to speak. So thank you for driving home some really important pieces about what that assessment, screening, and referral process looks like within the VA. Thank you also for the big job that you're doing, with the healthcare system that serves, as you mentioned, somewhere in the neighborhood of 10 million folks per year. It's a really big undertaking to have this universal, systematic approach. Also the pieces that you're doing with, raising awareness and universal training opportunities for such a big piece of the population is really important. So thank you, Dr. Bruce. Thank you, Ms. Kasdan. And I'll also mention that Dr. Hunter did have to, unfortunately, transition to another meeting, but I noticed that she answered as many questions as possible in that Q&A pod that came in during her presentation time. But now we will transition into some Q&A time with Dr. Bruce and Ms. Kasdan, focusing on the numerous questions that came in the Q&A pod. We'll get to as many of them as possible that are within the scope of where the two of you are working. So I'll first give a couple of questions to Ms. Kasdan. There were some questions that came in around data pieces, and there might be some information that you have to share here. There might be another data source that you might want to direct folks to. But a couple of questions that came in were specific to whether or not violence has increased after COVID. We heard a lot of stories in the news in 2020 when there were stay-at-home orders, and many are interested in what those data points actually came to look like in the following years.
It's such an excellent question, and it's one that doesn't just have a simple answer. So I'm happy to kind of frame what some of the concerns are. Kind of segueing into, some of the takeaways from the conversation today. What we know during COVID is survivors were trapped with those who are abusing them 24/7. And so they were not always free or able to safely make a call to a source that they might typically do. And I would like to just kind of give a couple examples of that across the life course. We know children were not going to school, so those that they may have confided in, whether that be a school counselor, if they're witnessing or experiencing abuse in their own home, they didn't have access to that person. Even doctors of all age groups, right, were having truncated type of appointments or more telehealth. And think about the whole development of telehealth and during the pandemic is that you might very well have the person who is using abuse in the same room as you or monitoring your technology. So for any survivor or family member, that may be unsafe. So that is a long wind up to say is that there have been some research studies done that, again, incidences they do believe increase, but the actual reporting in certain, times during the pandemic, sometimes it would be like really flatline, other times it might go up as emergency precautions were lifted. And so there still is more research and studying to be done. But in talking to other colleagues who work directly in hospital-based programs, one colleague said to me anecdotally, and I think this is important, when they were looking at their hospital-based data, they were saying that even when reports to the emergency room were going down, reports to, let's say, shock trauma or other places were going up because survivors weren't either able, because they weren't being allowed to access emergency room care because their abusers wouldn't let them, or they felt it was unsafe to do it because of COVID, but then the abuse would still escalate and then emanate in, unfortunately, greater and grave harm to them, which required a greater level of care. So more research to be done. The United Nations has termed this the shadow pandemic, what happened in terms of intimate partner violence during COVID. And so we know it really impacted survivors and their children in really detrimental ways. So I'm happy to follow up with, some research, but it's still under development.
Thank you so much. Appreciate information on how the pandemic really changed the context of how domestic violence was reported and those experiences. I wanted to shift a question over to Dr. Bruce. We've had a handful of questions come into the chat about caregivers, military and veteran caregivers. Some kind of specific questions about the VA's caregiver support program and how there might be support for a caregiver who is potentially receiving support through that program, but does report intimate partner violence in the home. So that unique perspective of caregivers who are experiencing intimate partner violence. Could you speak to that?
I can. That's a sister program to us. We work very, very closely with the caregiver support program because they are, acutely aware that with the additional stress of being a caregiver and a spouse or, intimate partner needing that kind of care, it can definitely exacerbate stress and relationship conflict and things like that. So they're wonderful. Their staff have been trained. We train them periodically all through their entire system, from leadership and assessors and program managers and everything. We, provide them with a lot of awareness and materials to, help their staff know what they're going to see, because they do a lot of home visits and telehealth and things like that to really, they know the dynamics of what's going on, and sometimes they pick up on some stress and strain. And make sure that they are able to pull the caregiver aside, and it can be, the other thing is, I can tell you something about working in this system and in this job is everything I ever learned about intimate partner violence and all the stereotypes and Duluth model and this, and that things I came into the door with have been shattered, because you automatically think about the caregiver being a woman and the person being, the veteran being a man, and potentially the caregiver being subject to abuse and, or the person acting out and things like that. And it can be totally the other way around. And it could be the caregiver, abusing the veteran. So we're very, very aware of and addressing through policy, through procedures, through training, and through support, those scenarios that might happen. So we would really want anyone who's in that role to be connected with the caregiver support program in some way so that, you know, they do have that extra layer of support.
Thank you so much. I also wanted to give Ms. Caston an opportunity to respond to that question if you'd like. I know that you have the background of working in support for older adults, as well as having that intersectionality of working in support for intimate partner violence. And, you know, outside of the VA, you might have some of that intersection as well, where there might be someone who's in need of care, and there's also a situation in the home where there's intimate partner violence. So wondering if you would like to speak to that from the kind of civilian perspective.
Sure, I'm happy to do that. And as we know, as our population ages, so is the need for caregiving. And so what we have again is incredible intersections of, you know, violence that can be happening in a number of ways. It can be happening between intimate partners in the home, and a caregiver who comes in may also be exploitative or somehow involved in you know, using abuse toward another one of those individuals. So just in my work in elder abuse, I can tell you that elder abuse is a bit broader than intimate partner violence. Elder abuse is comprised of intimate partner violence, family violence, and then third party type of abuse, which could be caregivers who are unrelated to them, like hired caregivers. It could be, you know, people who perpetrate fraud or scams, you know, economic abuse. So it could be any number of things, but caregivers who are in the home, and also I wanted to make this point too, is that we oftentimes have multi-generational families too living in the same home. So we may have someone who is being abused by their intimate partner, their son or daughter, their grandson, granddaughter, and also the caregiver. So sometimes the caregiver, as I always say, there's no clear definition of who are the good people and the bad people in the scenario. Sometimes we have caregivers who are, of course, not abusive at all and can be in tremendous advocates and flag abuse when it's happening. And other times, unfortunately, they also may be the ones utilizing abuse toward another one of the individuals. So every situation, while different, there are some common themes. And we know that as the population is aging, so is the incidence of abuse with older adults across the life course. And that is being both within intimate partner violence, family violence, and then what I call third-party caregiving, unrelated familial relations who may be also using abuse.
Thank you, Ms. Caston. You know, really important to look at that, the whole system in terms of families and homes. I have a question that I'd like to turn to Dr. Bruce next. There were some questions that came into the chat. I know you touched on this a little bit, but there were a number of questions that came into the Q&A pod about confidentiality in the medical record, since this is a healthcare system that the VA is functioning as. So wondering if you could speak to that piece a little bit more about how confidentiality is preserved.
Sure, absolutely. Just like any healthcare system, we have an electronic health record governed by HIPAA. So obviously in our scenario, there wouldn't be any conversation between, and in our scenario, both were veterans, so they both have their own individual healthcare record. The providers are restricted by HIPAA laws and so forth. So there would be total confidentiality, except for the limits of confidentiality, you know, that always exist in the healthcare system if someone was going to hurt themselves or someone else and so forth. So we talk about those limits of confidentiality even as a part of the preliminary screening protocol. But also, if I wanted to mention that if a non-veteran spouse were to come and talk with us, you know, obviously we have to document something, you know, somewhere. So we actually have the ability to create an electronic record for the spouse completely separate from the veteran partner's health records, so that, you know, there isn't any possibility of them being, you know, seeing what's written in the, or even knowing that the spouse has a chart.
Thank you for that information. We also had a couple of questions that I'll pose to both of you in terms of practices on screening for use of violence. I know that many systems have screenings for experiencing intimate partner violence, but does the VA, for you, Dr. Bruce, or any general sector, civilian sector entities have any universal screenings in terms of using violence? I'll open that to both of you, whoever would like to respond first.
Ms. Kasdan, would you like to go first this time?
So screening tools to assess violence. So I think it really depends. So the one I'm most familiar with is Jackie Campbell from Johns Hopkins University, the danger assessment. But again, we need to talk about what populations. So that is a very appropriate screen for women of certain population, a certain age, maybe who have children. But if we're talking about, let's say, an older adult or someone from a marginalized community that may not experience violence in the same ways, LGBTQ, others, culturally specific assessment tools, it really depends. So while certain mainstream tools have been widely used and are evidence-based, there's also been a movement in recent years to understand that how we talk about violence, how we experience violence is very culturally specific, very person-centered. And so there have been, some development and research on other types of tools that speak to more population-specific experiences. And Dr. Bruce, you may want to add on to that as well.
Yeah, I'm glad you mentioned the danger assessment. We love Jackie Campbell. She's one of our big cheerleaders too. And all of our coordinators are required to be certified in the danger assessment training. So we work closely. It's wonderful to look at risk. But when it comes to assessing or screening for use, that's really tricky because, as I mentioned, there are validated screenings out there, but if you look at them, they live more in the correctional, world and prosecution and things like that. It's really out there. It's not trauma informed. It's not veteran centric. It doesn't really. They don't lend themselves to being respectful of where the person has been and things. It's very point the finger at you kind of thing. And so we've not found a validated screening tool at this time that we would really endorse to screen for use. But we work really closely with Dr. Galena Portnoy and her team we partner with them at Connecticut. She's in the research division at Connecticut, and she's absolutely amazing. And she's been doing work for the last 3 or 4 years validating a bidirectional screening tool that really takes kind of our screening that we showed you a while ago and asks it in both ways. And it actually lends itself very well to be able to ask someone if you have, experienced or used this behavior in your relationships. And that way you kind of open the door to talking about some behaviors that someone might want to change and improve. So that's been piloted. It's being revised right now for some more testing, but that's the closest, we think, and we see so much bidirectional, situational, contextual, so much more of that where people really do want to have healthy relationships, but they just don't know how, or the stress of life has just kind of overwhelmed them. It lends themselves very well to some of our interventions.
Thank you so much. We have about 1 minute remaining, so I wanted to give each of you about 30 seconds to give any final thoughts or any final points that you would like to give to the group. Ms. Kasdan, I'll go to you first.
Thank you, Stacey. I would just emphasize how important it is to recognize that there's just not one form of abuse. Many forms of abuse are co-occurring. And again, as we talked about today, we want to be person-centered, trauma-informed, and really allow the person experiencing abuse to tell their story. That can take a longer time, but is really important to create best outcomes. Building partnerships is really important, and I hope everyone will take advantage of doing that in their communities. Thank you so much for having me.
Thanks, Ms. Casper.
And I would just echo, oh, sorry. I would just want to echo everything you just said. I completely agree. And, we're here for the veterans. I just would encourage anyone that if you have any questions or know someone who needs assistance, please, I put the link to our website with our directory in the chat box, and don't hesitate to reach out to us. Thank you for letting us come and present today.
Thank you so much to all three of our presenters. Really appreciate you lending your subject matter expertise to us today. Also to this group that logged on for this webinar, we appreciate you taking your time to learn more about this important topic, as well as the work that you're doing to impact the service member veteran and their family community where you live. I think we might have one more slide. This is the information for SAMHSA's SMVF TA Center. Feel free to review our website and send an email if you have any questions. We do have webinars like this on a quarterly basis, as well as other events that you can take advantage of. Thank you again, and enjoy your day.